when we put in a pulmonary artery catheter, remember that there's a bunch of different types of pulmonary artery catheters that are out there. We're going to look at one particular one. So, when we look at a pulmonary artery catheter, remember the way the catheter is designed. It's typically somewhere between like 70 and 80 centimeters long. They vary in length, they vary in size, but an average size swan is usually like a 7 French or an 8 French swan. And one thing that is worth knowing is if you're going to be putting a swan through a cordis, you always use a cordis that's one size bigger than the swan. So for instance, this swan right here is actually this is actually an 8 French swan, so we would want to put in a cordis that's bigger than an 8 French. We'd want to put in like a 9 French or a 10 French cordis. Okay, so let's look at this particular swan. Let's start at the business end right here. When we start at the distal end, remember that the distal end, you actually have a hole right here at the distal end. That hole is actually called the distal port. And that distal port runs the entire length of the swan, and it actually dumps out at this channel that's on the very distal end right here. And you'll notice that again they've made it idiot proof. On the distal end right here it says pulmonary artery distal. So this port again runs the entire length of the swan, runs all the way through and runs to the end. Now when we talk about this port, it's real important that you know a couple things about this pulmonary artery distal port. The first thing you need to know about this pulmonary artery distal port is this port exists for one reason and one reason only. The only reason we use the pulmonary artery distal port, actually I say one reason, there's two reasons. The main reason why we use the pulmonary artery distal port is we're going to use this to transduce to get a continuous pressure waveform of what's going on in the pulmonary artery. The second thing that we can use this pulmonary artery distal port for is we can actually draw blood from it to get a pulmonary artery blood gas, which we call an SVO2. SVO2 is the saturation of venous oxygen, and this is the best place to get a complete mixing of all the venous blood that's on its way to the lungs. So remember again, this pulmonary artery distal port exists for two reasons and two reasons only. The first reason we use it is we transduce it to monitor pressure, and the second reason we use it is to get an SVO2 blood gas. Now, that brings up some important points about the PA port. There are lots of things that we don't do with this port. When we talk about the things that we don't do with this port, we don't use it to administer IV fluids. We don't use it to administer blood products. We don't use it to administer medications. So in essence, the big thing to take away is this PA distal port is not a central line. It is not a line that we push drugs or fluid through. I'll say that again because it's an important teaching point. The PA distal port exists for two reasons and two reasons only. We transduce it for pressure and we use it to draw SVO2 blood gases. We don't use it as an IV. We don't push fluids through it. We don't push drugs through it. We don't push blood through it. Any of that good stuff. Okay, now it may be kind of hard to see because of how small the picture is, but right next to the distal port right here, there's actually a little tiny balloon. And if you look at the picture here, in the picture you actually see that that balloon is inflated. This little tiny balloon is actually designed so that when we inflate it, this is what allows us to separate the right side of the heart from the left side of the heart. Because when the balloon is inflated and we're monitoring the pressure in this distal port here, when we're monitoring that pressure, when the balloon inflates, that creates what's called a wedge. It separates the monitoring port from the right side of the heart. So we're just basically looking down the pulmonary circulation in the left side of the heart. So when we inflate that balloon, whenever we do that, we're wedging the catheter. And there's kind of two thoughts on how this occurs, and really both of them are right. When we inflate this balloon, if it's sitting right where it's supposed to be in the perfect size pulmonary artery, when we inflate it, what's happening is the balloon itself is completely occluding the pulmonary artery. If it's sitting in a place where it's a little bit too big, then when we inflate the balloon, that balloon acts as a sail, and it may actually drag that catheter forward just a little bit to where we have a narrowing of the blood pressure, or excuse me, a narrowing of the blood vessel, and again it wedges it in place. So we use this balloon to wedge the catheter. Now, if we follow this balloon, if we follow all the way up through the swan, there's actually a channel inside. This balloon is actually going to lead to its own port. And its own port is typically red. Not always, but is typically red. Now, this port actually has a syringe attached to it. It's really important that the syringe that comes with the swan stay with the swan. This syringe is actually a specially designed syringe. When we look at this syringe, it looks just like any other 3cc syringe, but it's very different. This syringe is actually designed so that when we inflate it, it's going to inflate the balloon to the maximum amount the balloon can hold. When I pull back on the syringe is designed so that it will not allow me to pull any more air back other than what the balloon is maximally designed to hold. So for instance, this particular balloon is designed to hold 1.5 cc's of air. So this syringe is designed so that the maximum I can pull it back is to 1.5 cc's. That's a huge, huge safety measure, and that syringe needs to stay with that swan. Now also on the port, you'll also see that there's also this little clamp right here, and this clamp slides one way or the other. This clamp is actually designed so that when it's sitting where the red line is straight in line, we have the ability to inflate the balloon and to deflate the balloon. When the clamp is flipped to the side like this to where the red line is broken, that has locked this closed, so we no longer have the ability to inflate the balloon. That's a big important safety feature as well. And generally what we say is that we want to make sure that all the air has been sucked out of the balloon, and then we usually want that to stay closed so that that balloon doesn't inadvertently get inflated by the syringe inadvertently being pushed. And the reason why that's so important is because when this syringe is pushed and we've filled this balloon, as long as this balloon is inflated, what disease have we just created? Well, we've basically just created a pulmonary embolus, because as long as this balloon is inflated, we've blocked all the blood flow in that particular branch of that pulmonary artery. So we never ever want this balloon to be inflated except for when we purposely inflate it. Okay, so let's look at a couple other things on this particular swan. On this particular swan, we've already talked about the balloon port, and we've already talked about the PA distal port. Now, when we look at this particular swan, you actually see you've got two other ports here that are just hollow channels. One of these ports is actually labeled a proximal injectate port, and the other port actually says the same thing. It says proximal injectate port as well. These two ports are actually designed so that they run the length of the swan, and they actually end up dumping out somewhere around 20 centimeters or so on the swan. And when I look at this particular one, let me see if I can find the little holes. There's the hole right there. This particular one is actually designed so that it dumps out at 15 centimeters, and the other one dumps out somewhere around 12 centimeters. Now, when this swan is sitting in the body the way that it's supposed to be, typically what we'll see is that it'll actually coil like this. This distal tip is actually sitting in the pulmonary artery, and this coil is actually in the right ventricle. Now, these particular ports, these two ports, these injectate ports, are actually designed so that they should be sitting in the right atrium or in the central circulation. I'll say that again. These two injectate ports are designed so they should be sitting in the right atrium or in the central circulation. Now, these two ports are actually designed as injectate ports. Okay, so what in the world is an injectate port? Well, if you look on this swan, you actually see that there's actually, let me see if I can find it here. There's actually, it's really hard to see, and I'm sure you're not going to see it on the video, but there's actually this little tiny dark spot right here. This little dark spot right here actually runs the length of the swan, and it actually dumps out right here at this cord. This cord is actually designed to plug into something called a vigilance monitor, and all this cord does is provide temperature. So all this is right here is a thermometer probe. And in our older swans, the way that we would get cardiac output is we would use these injectate ports, these two ports right here. What we would do is we would attach our swan to the vigilance monitor, and then what we would do is when we wanted to know somebody's cardiac output, we would actually attach fluid to one of these injectate ports that was at a specific temperature, and it was also connected by another cord to the vigilance monitor. So the vigilance monitor would be monitoring two temperatures. It would be monitoring the temperature right here, which was inside the body, and then it would be monitoring the temperature of the fluid that was attached to either one of these injectate ports. And so it knows the difference in temperature between these fluids. And when we wanted to know somebody's cardiac output, what we would actually do is we would have a syringe that sat in line of this injectate port. And what we would do is we would fill the syringe up with a given quantity of fluid. Usually it's like 10 cc's of fluid. And then what we would do is we would push that fluid as hard and as fast as we could. And what the vigilance monitor is going to monitor for is as that fluid is ejected through the injectate port into the right atrium, as it mixes with blood and it runs past this little thermometer that sits on the swan, we're going to see that that mixing of cool fluid with the warm blood is going to cause a drop in the temperature. As that temperature drops, and then as the fluid continues past it, all the fluid, and now we're back to just having blood pass by. Based on how fast that happens, the temperature would actually create a waveform. So we have a drop in the fluid and then a transition back to the patient's baseline as all that cold fluid rushes past. Based on that curve, it actually could come up with it did a bunch of math that's like way above and beyond my head, and actually gave you a cardiac output. It could actually tell based on that curve how quickly that blood passed by, thus how much blood was flowing through the heart in a minute. That's the old way that we used to measure cardiac output. Now this particular swan, this is a really high-end swan. This swan is actually what's called a CCO swan, or a continuous cardiac output swan. And what makes this swan different than the old swans is it actually has this coil right here that's made out of metal. And if you can see this coil actually is designed so that it goes up all the way to the end of the swan and dumps into this other cable right here. This cable goes into the vigilance monitor as well. So on this particular swan, on the continuous cardiac output swan, you actually have two separate cables that attach into the vigilance monitor. And the way that this one works, we don't have to mess with any of that injectate junk anymore. Instead of having to have that extra bag of fluid and the syringe and push it and all that good stuff, we don't got to do that anymore. With the continuous cardiac output swan, it's actually designed so that at predetermined periods, and it's something that you set in the vigilance monitor, whether it's set at like every 30 seconds or every 60 seconds or whatever, this actually is going to heat up. And when it heats up, what it does is it actually heats up the blood that passes by it. And again, this temperature monitor is watching, and as the blood heats up, passes by it, and then returns back to baseline, it creates a curve, and based on that curve, it can give us a cardiac output. So these continuous cardiac output swans are really cool because we don't have to do anything. The machine does it for us, and it does it on a regular basis. Now, the big thing you need to know about the continuous cardiac output swans is continuous is kind of a misnomer. It's not really continuous. It's not doing it constantly, but it is doing it at predetermined intervals. And usually what we'll do is we'll set it at like once every 60 seconds or once every 90 seconds or something like that. Now, as we look at this particular swan, we've gone through and we've talked about all these different ports. We said that these two were injectate ports, and we said what they used to be for. Well, we said that this was a continuous cardiac output swan, so why in the world do we have injectate ports? Well, these injectate ports, actually, we don't even need to inject anything through them anymore. On this swan, and the continuous cardiac output swan, really these injectate ports are just central lines. So what do we do with them? Well, we can do anything with these injectate ports that we would do with the central line. So one of the things that we can do is we can transduce this to get a CVP. So actually, if we put one pressure setup on the distal port here, and one pressure setup on one of the injectate ports, with this one catheter, we can actually continuously monitor the PA pressure, and we can monitor the CVP. The other thing that we can do is we can use it just like any other central line. So that means the injectate ports, we can push fluid through them, we can push blood through them, we can give meds through them, we can do anything with these that we would do with a central line. We can also draw blood from these to get what's called an SCVO2, which is a saturation of central venous oxygenation. So we can do lots and lots with these injectate ports. So they're very handy. But the one thing I got to caution you on, again, we've talked about it, but it's worth mentioning again, is remember these two injectate ports, they sit in the right atrium or right outside of it, so we can use them just like any other central line. We can push fluid through them, we can push drugs through them, blah, 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 blah. But when we talk again about the PA distal line, remember that that's the one that's different than the other two. Remember the PA distal line, the only thing we can do with it is transduce it and draw blood from it. So while these two injectate ports can be used for meds and things like that, this PA port cannot. And so it's really important when you're taking care of somebody that you go through and you look at the names of all of these different ports so you know exactly what goes where and what does what. Now, this particular swan has one last thing on it that's really, really cool that you need to know about. The last connection that was on there was actually this blue connection right here. This blue connection also plugs into the vigilance monitor, and this blue connection is actually just a fiber optic cable. This fiber optic cable runs the entire length of the swan, and at the end of the swan, again it's going to be hard to see because it's so small, but right next to the hole where the distal port is, you also see this other little black line. That black line is actually the end of the fiber optic cable. And this fiber optic cable is actually just a pulse oximeter. So when we stick this into the vigilance monitor, what we have is we've got a continuous waveform that allows us to bounce light off hemoglobin, and we can get a pulse ox off of this as well. Well, what's the advantage of that over having, say, a pulse ox on the finger? It's huge. Because remember the pulse ox on the finger, that's giving us pulse oximetry coming out of the heart. This pulse ox, which we call the SVO2, is giving us pulse oximetry coming back into the heart. The continuous cardiac output swan is an incredible device, not just because we can monitor the PA pressures and the CVP pressure and the cardiac output and all that other stuff, but it's also a phenomenal device because it's got this ability to monitor SVO2. And when we have a pulse ox in coming off our finger or toe or whatever that's giving us oxygenation coming out of the heart, and I've got an SVO2 telling me what oxygenation is coming back into the heart, that gives me a tremendous amount of data about how much oxygen a patient is actually utilizing. And when patients start to have an increase in when they start to have a decrease in their SVO2, what that tells us is that they're using more oxygen. So when we have an increase in the SVO2, we need to think, is the patient hypermetabolic? Is the patient febrile? Is the patient anemic? And therefore they're extracting more oxygen off of hemoglobin, and so on and so forth. When the SVO2 starts to go up, that tells us we're using less oxygen. So what would cause us to use less oxygen? Well, if we're cold, if we're hypometabolic, or the other big thing that would tell us, or the other big reason why we would have more oxygen returning to the heart that's not being used, is because there are more cells that are dead. So we use these a lot in sepsis to watch our VO2 and see exactly how much oxygen we're using. And if you want more discussion about that, we talk about that lots and lots in our respiratory section. So that's the Swan-Ganz catheter. Now let's talk about the actual technique of measuring the cardiac output if we're doing it the old-fashioned way. Remember, we said the old-fashioned way we measure cardiac output. If we don't have one of these continuous cardiac output swans, we said the way we did that was we actually used injectate through a distal port. Now, we've already talked pretty heavily about how to do that. There are just a couple other things here that are important to know. When we talk about actually shooting a cardiac output with the old injectate monitors, remember that if you're shooting the cardiac output, you want to make sure that the temperature of the fluid is known by the monitor, and that's why the fluid itself will have its own temperature sensor, just like the patient has a sensor inside of them. You want to make sure that that's set up and that's calibrated appropriately. And when we go to shoot our cardiac output, as we go through our menu on our monitor and we say, okay, I want to shoot a cardiac output, and it says, okay, go. Remember that you want to push the fluid that you've set, so usually it's 10 cc's, and you want to push that as hard and as fast as you can. It's not like when we push an IV drug. Usually when we're pushing IV drugs, we teach you to push them really, really slowly, nice and gently, over time. When we're shooting a cardiac output, we don't do that. When we're pushing the fluid, we want to push that fluid hard and fast as fast as we can. The second thing you want to know about shooting a cardiac output, if we have to do it manually, is you always do it 3 times. So we're going to shoot our cardiac output, let the monitor do its calculations, set it up, do it again, let the monitor do its calculations, and then we're going to set it up and do it a 3rd time, let the monitor do its calculations. And then based on the cardiac output that we get over the 3 times, we're going to take those 3 separate cardiac outputs, add them together, and then we're going to divide by 3 to give us an average, and we use the average cardiac output as our work point for for our hemodynamic computations and for our values. So remember, we always shoot a cardiac output 3 times. Okay, we've talked a whole bunch about the Swan. Now let's actually talk about the fluid monitoring system. Actually, we've talked about all 3 catheters, and we keep talking about how we're going to transduce it. So what is transducing it? Well, remember when we hook up a central line or a Swan or an arterial line, whichever catheter we're monitoring for pressure, remember that the way that this is designed to work is we actually are going to take a bag of fluid. And it doesn't matter which fluid we use. We can use any kind of standard fluid. This particular fluid is lactated Ringer's, but most of the time what we'll just use is normal saline. We're going to take normal saline, and if the catheter is really, really small, like if it's a peds patient, a lot of times we'll actually add heparin to the fluid. But for most of our adults, most of the time now, we don't need to put heparin in the fluid. So we're going to take this fluid, and we're actually going to attach a transducer setup to it. So let's look at the transducer setup. When we look at the transducer, at initial appearance, it looks just like any other IV tubing. You've got a spike and you've got a drip set right below that. You've got a roller clamp just like any other IV tubing. But there are a couple things that are different about this transducer tubing. The first one is this transducer tubing is thicker and it's more rigid than IV tubing. It's designed to not stretch well. It's designed to be fairly rigid. And as we continue on down this transducer, you'll see a couple other things that this transducer has. As we continue down, you actually have, as we continue down this tubing, you actually have a transducer itself. Now this transducer, the easiest way to describe this is just like a little flapper valve. And the way that this system is designed to work, when we take this and we plug this into our fluid, we're going to take our fluid and we're going to put it under pressure and we're going to put it at 300 millimeters of mercury. Now at 300 millimeters of mercury, this tubing is designed so that it's going to allow a specific amount of fluid to run down at a time. And usually these systems are set up to administer about 3 cc's of fluid an hour. So we're going to take our IV tubing, we're going to close our clamp first, we're going to take our IV bag, I should say, and we're going to take our transducer and we're going to pop it right into our bag. Just like you would spike an IV setup. This particular one is rather stiff. Now, once our spike is in there, we have a whole bunch of air left in this bag. In the ICU, we don't really care about that, but in the transport setting, we don't want any air to end up in this tubing. So if you're going to be transporting this patient, and you're going to be transporting them if you're going to be transporting them inter-facility, a lot of times what we will do is we'll actually, once we've poked our transducer in, we'll actually take our transducer back out, and then what we're going to do is we're going to take our bag, and we're going to remove all the fluid we can from it. Now, once we removed all the fluid we can, then we're going to spike it again. And now, there shouldn't be any air or a very relatively small amount of air inside the bag itself. Now, if you're transporting this patient, what we're going to do is actually, we're now going to open this roller clamp. And what we're going to do is we're going to squeeze fluid retrospectively back up into the tubing. Now, on this setup, you'll actually see that when we look at the transducer, it's actually got this little rubber tail right here. This is called a pigtail. When you pull on this pigtail, when you pull it out, what that does is that opens the tubing wide open. By doing that, that allows us to flush the tubing. So we've opened our roller clamp. Now what we're going to do is we're going to squeeze our bag while we pull on this little transducer. And that's going to allow us to fill up the tubing. Now, if we hold it upside down like this, this allows us to get the vast majority of air out of the actual tubing itself. Now, once we've got all that air out, the advantage to this, I've still got lots of air in there, but the advantage to this is that once we have all this air out, we now don't have to worry about what we're going to do with this bag. We can take this bag and do whatever with it. We can take it and we can throw it on the patient's lap. We can hang it. We can drop it on the floor. It doesn't matter because now we no longer have concern about getting air into this line. Now, once we flush this tubing still obviously got a bunch of air in it, but once we had cleared all the air out of the tubing, then what we're going to do is we're going to take the bag and we're actually going to pressurize it. Just use a regular pressure bag for this, just like you would use to administer fluids quickly or anything like that. And when we look at a pressure bag, remember that on your pressure bags, they actually have this little pressure monitor right here. And actually that pressure monitor was actually made for our central lines. Or excuse me, for transducing pressures. So what we're going to do is we're going to flip this to where it's open to the bag, and obviously we're just going to squeeze it just like we would any other pressure bag. And what we're looking for here is as this bag begins to full, or this bag becomes full, and that little pressure tab starts to slide out, we're actually looking for this bag to be filled to 300 millimeters of mercury. And on this bag, you'll actually notice that when we look really, really closely, 300 is actually marked. When we get above 300, you'll see that this turns red, and you'll also see that there's a pop-off, so you can't overfill the bag. If we go above 300, you'll see that it just allows air to escape. So we want this to be right at 300. And the reason we want this to be right at 300 is because this transducer on this tubing is actually calibrated to work based on 300 millimeters of pressure. So now I've got my transducer bag all hooked up. I've gone through, I've flushed all my tubing, and I've made sure that all the air is out of the line. Now I've got this all set up, it's all ready to go, and what I'm going to do is I'm actually going to go back over here to this transducer, and I'm actually going to again flush the line and make sure there's not any air anywhere in the line. And now the line is under pressure, so lo and behold, when we actually pull, you'll see that fluid shoots right out. Okay, so now it's all under pressure, and we want to make sure again we've got all the air out of the line. So we're just going to let it run here, get all the air out of it. Almost have all the air out. Okay, so now all the air is out of the line. And believe me, it's a lot easier to do this when you're not sitting in a chair trying to do this with no hands while you're being recorded. And we're going to go and we're also going to make sure that each one of these stopcocks, there's a stopcock here, there's a stopcock here, that it has also been flushed and we've gotten all the air out of those stopcocks. So now it's all set up, it's all ready to go. So what we're going to do is we're going to actually take this and we're going to actually attach it to whichever line we're using. So for instance, if we're using let's say just an art line, then we would take this distal tip and we would put it into the art line. Now once we put it into the art line, then the next thing that we need to do is we actually need to close the stopcock that's closest to the patient. So you'll see that here's the distal tip of it, here's the stopcock right here. So we're going to close this to where it's close to the patient. So when we closed it to the patient, what we did was we just opened it up to air. This is now open to the environment. Now what we're going to do is we're going to go back to our monitor. We're going to attach this particular cable right here to our monitor, and then what we're going to do is we're going to transduce it. And on every monitor it's different. You'll have to go through the procedure on your monitor to transduce it. And once we've done that, then what we're going to do once we've gone through and we've gone through whatever settings and the monitor tells us, okay, your line is now zeroed. That's the magic words we're looking for, zeroed. Once it's been zeroed, then what we're going to do is we're going to take this and we're going to turn it back off to air, back open to the patient. Now this has already been attached to a line. The monitor's been zeroed, so at this point you should have a waveform. You should see on your monitor that you've got whatever waveform this is attached to. So we said we were attaching it to an art line, so we should have a nice pretty arterial waveform. Remember that this transducer actually has to be at a specific place. This transducer actually has to go at something called the phlebostatic axis. Well, what's the phlebostatic axis? Well, that's really just a really fancy way of saying the right atrium. So wherever the patient's right atrium is, we want to put this transducer really close to that same height. And so the easiest way to do this is actually if we just take this transducer and we just tape it to their chest. If we tape it like right about mid-axillary, somewhere around 4th or 5th intercostal space, that actually would be pretty close to even with the right atrium. If we can't get to that, let's say it's a spinally immobilized trauma patient, then we can also take it and we can just tape it to their bicep. And in the ICU, because we have nothing better to do and we like to make our lives miserable, what we'll do is we'll actually take this and we'll actually slide it into a slot on the IV pole, and then we'll take a balancer or a device that allows us to see that things are equal, and we're actually going to equalize it, make sure that it's where it's supposed to be and that it's equal with the patient's right atrium. Okay, so we're almost done. We've pretty much done everything we need to do with this. The last thing that we're going to do is we're going to do something called a fast flush test. So remember we said that when we pull on this pigtail, it makes the system, because it's high pressure, it makes it shoot out fluid. So when I shoot out this fluid, it's shooting it out at 300 millimeters of mercury, because that's what the pressure bag is set at. So since the pressure bag is set at 300 millimeters of mercury, when I pull this and I open it up, fluid shoots out at 300 millimeters of mercury. The last thing we're going to do is something called a fast flush test. So once this has been set up, transducers on the chest, we've removed all the air, we've zeroed the monitor, blah, 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 blah. Then the last thing we're going to do is we're going to actually take this little pigtail and we're going to squeeze it, and we're going to watch what happens to the patient's waveform on the monitor. And when we pull it, we should see a sharp upstroke followed by a plateau. And that plateau should be in place as long as fluid is being shot out of the system. As soon as I release it, then obviously the system should stop. As long as fluid is being shot out at 300 millimeters of mercury, that means there's 300 millimeters of pressure in that blood vessel, so there should be a plateau in the waveform along the top. What we care about is what happens when we release the pigtail. And when I release it, what I should see is that I should see that pressure immediately drops down, but there should be some recoil there. And what we're measuring here is we're measuring actually to see if there's something called damping. Damping is how resistant how sensitive is the system to changes in pressure. And we can have normal damping, we can have excessive levels of damping, or we can have inadequate levels of damping. And we call the excessive levels of damping, we call that over damping. And if there's not enough damping, we call that under damping. So when we look here at these three waveforms along the bottom, you'll see that you've got a cardiac cycle, and then you've got a sharp upstroke plateau, and then you've got a couple of bounces, and we go back into the first cardiac cycle. When we look at the graphic when we look on the bottom at the waveform that's all the way to the left, that is perfect damping. That is exactly what we want to see. We want to see that when we release this, there's sharp downstroke, probably 2 or 3 little bounces, and then we go back into a waveform. That's perfect. That tells us that system is set up, that it's primed, that it's good to go, that we've got the ability, this transducer has the ability to rapidly sense changes in pressure, and we are all set. Now let's look at the second little group of waveforms there. When we look at the second little group of waveforms, what we see is that when we pull on the transducer and we release it, there's an immediate drop and there's no bounces. It just goes right back into a waveform. That is called overdamping, and that tells us that the system is not dynamic enough. That means that the system is too stiff. It's not bouncing and moving like it should, so that's a problem. Finally, when we look at the last one there, when we look at the last waveform set, the one that's all the way over to your right, in this situation, when we release the pigtail, what we see is that there's all these little bounces before we go back into a waveform. That is called an underdamped system. And when we talk about underdamped systems, they are problematic as well as the overdamped systems. So we don't want the system to be overdamped, and we don't want it to be underdamped. If the system was overdamped, like in that middle example, what that tells us is that there is resistance or blockage somewhere. So what that means is that we need to now go back through our whole setup, and we need to make sure all of our stopcocks turn the way that they're supposed to. Is our pressure bag at the pressure it's supposed to be at? Do we have any kinks or anything, any bends in the tubing or anything like that? And if so, we need to clear out those blockages, and that should stop an overdamped system. When we talk about the underdamped system, remember that the underdamped system was too dynamic. There was too many bounces there. We would like to see like 2 or 3 bounces, but we don't want to see that when we release the pigtail here, we don't want to see it go zzz. We just want to see it go do-do-do and then back to a regular waveform. If it goes zzz, and finally thins out, what that tells us is the system is too dynamic. Well, what would cause the system to be too dynamic? Anytime that there is air in the system. If there is air in the system, that is going to cause underdamping. So anytime we see an underdamped waveform, anytime we see that long crescendo down to a regular waveform, we need to go back and look and figure out where there's air at. Is there air anywhere between the transducer and the patient? Now, the other thing that could cause this system to actually be underdamped is if the pressure bag is not inflated high enough. So we also want to go back and look at our pressure bag and make sure that it hasn't become hypoinflated. So again, what we're going to do, just starting from the top as we walk through all this one last time here. Remember, the first thing we wanted to do was we wanted to remove all the air from the bag if we could. Once we've done that, then the next thing we want to do is we want to flush the entire pressure line with fluid. Remember that we have to pull the pigtail to open it to do that. Then what we're going to do is we're going to take our bag and we're going to actually put it on a pressure bag. We're going to fill the pressure bag to 300 millimeters of mercury. And then what we're going to do is we're going to flush all the tubing to make sure we get all the air out. Once we've done that, then we're going to go back and make sure we've got all the air out of our stopcocks. And then what we're going to do is we're going to find the stopcock that is closest to the patient, this particular one, and we're going to actually turn that off to the patient, open to air. Then we're going to zero our monitor. Once we're done zeroing our monitor, then we're going to take this stopcock and change it back to where it is closed to the air, open to the patient. We're going to take our transducer and we're going to put it equal with the patient's phlebostatic axis. And then finally, after we've connected our tubing, the last thing that we're going to do is we are going to go through and do the fast flush test to make sure that we don't have overdamping and that we don't have underdamping and that the system is all good to go and it's working the way that it's supposed to. If we've done that, then we should be good to go. And finally, the last thing you want to do is if we're doing an art line, you also want to correlate that art line, the pressures that you're getting, to an NIBP. And ideally what we want to see is that the NIBP and the intra-arterial BP from our pressure setup are within about 10 to 15 of each other. So for instance, if we had an NIBP of say 120, we would expect our art line systolic blood pressure to be somewhere between like say 110 and 130. Usually within about 10 to 15 millimeters of mercury of what our NIBP is. Having said that, remember what we said about NIBP. The more hypotensive we are, the more it becomes inaccurate. So if you've got a patient who's really unstable, if you've gone through, you've done all your setup, you've checked all your equipment, you've got a good square waveform, your pressure bag's where it's supposed to be, your transducer's where it's supposed to be, sitting at the phlebostatic axis, and you've got a big difference between your NIBP and your intra-arterial BP, I would believe the intra-arterial BP, because remember, that's actually being measured directly in the artery. So that's actually going to be the more accurate number, most likely. Okay, so we've talked about how to set the system up. What if you're going to be transporting a patient who has this system? Remember that if we're transporting the patient, there's some specific concerns that we really need to be worried about, especially if we're going to be flying this patient. Remember we said we want to remove all the air from the system. We want to make sure that all the air is out of the transducer, because remember, even small pockets of air, as we go up in altitude because of Boyle's law, they're going to get bigger, and because they get bigger, they can become a lot more problematic. And the more air we have in the system, the more likely it is that we're going to have an underdamped waveform. So as we go up in altitude, we expect that any small amounts of air are going to become big amounts of air. Now, remember what we said about the transducer. Remember in the ICU we said we typically take it and we put it on the pole and we take our little level and make sure that it's equal. But in the transport environment, it's definitely easiest to just take that transducer and tape it to their bicep or tape it to their chest. Remember, if you're going to tape it to their chest, usually like around 4th or 5th intercostal space, mid-axillary is close enough that you're going to get the numbers you need. And remember, obviously, that if they roll onto their side, you need to move the transducer to where it's still equal with the right atrium. Okay, some other things to think about. These systems, when they're designed, they usually come with like 800 feet of tubing. So one of the things that you may want to do is go through and identify which tubing you can get rid of. A lot of times you've got a lot of excessive tubing, and the more tubing you have, that's going to vibrate, and that can make your waveforms more difficult in transport. So one of the things you may want to do is see if you can mitigate some of that tubing and lose some of that tubing before you take the patient and put them in the ambulance or in the aircraft. Now, one other thing to think about, or two other things to think about, remember that the pressure bag is designed so that as you go up in altitude, as that pressure bag expands, as the air inside grows, we're not going to see a big change in our waveform or a big change in our system, because the pressure bag's designed that as it goes above 300 millimeters of mercury, it's self-vent. So you should expect that. You should be watching for that and expect that as you go up, the bag is going to self-vent, the pressure bag. That's fine, but what we are concerned about is that as we come back down, as we come back out of altitude and start getting closer to the ground, that bag is going to start to deflate as the air inside contracts. So you definitely want to be watching that really closely, and as we start our descent, we definitely want to go back and reinflate the bag and make sure that we get the pressure back up to where it's supposed to be. Finally, one last thing that is an important point. Remember that when we zero the transducer, the whole reason we're doing that is we're telling the monitor what the ambient air pressure is so that it can take that out of the equation of the patient's pressure. When we take a patient and zero them in the hospital, and then we take them and we go and we put them in a cold ambulance, or we take them and put them in a helicopter and lift off to altitude, well, whether it's a change in temperature or a change in altitude, those are both going to change the ambient pressure. And so we want to re-zero the monitor each time we change the pressure because of a change in temperature or because of a change in altitude. So that doesn't mean that you need to continuously sit there and re-zero it, but as a general rule, once we get up to our cruise altitude, we probably want to go back and re-zero our line again. And then once we start our descent, when we get back down towards the ground, we want to re-zero our line again. And certainly, even if we're doing this as a ground transport, if we're going up over mountains, or even if we're changing temperature, going, say, from a nice warm hospital room to a cold ambulance, we also want to re-zero with any change in altitude or any change in temperature. Okay, this seems like a pretty good place for a break. Let's take a break, and when we come back, we'll continue on with our discussion of hemodynamics. In the interim, I hope that you have a great day, and I'll see you soon.
I'd come for you, no one but you. Yes, I'd come for you, but only if you told me to. And I'd fight for you, I'd lie, it's true, give my life.